All right. Thank you very much. Good morning, afternoon, evening, ladies and gentlemen. It's my absolute pleasure to welcome you to the 7th wave of the Arab Thyroid Association webinars. The Arab Thyroid Association, as many of you might know, is a non-profit organization. It's quite a young association as it was established only last year, 2021, with no known key opinion leaders in thyroidology in the Middle East region. Of those, I name Dr. Nasser Jahani, Dr. Wayam Hussein, Dr. Thamer Isa, and Dr. Iman Sadiqi. So this group of pioneers, they put together the pillar and the sound base of this association with the mission of making this as a nucleus for further thyroid research and improvement in the areas or aspect of thyroidology. The association has already ran 6 webinars before, and I'm delighted that pediatric thyroidology is included in this series of webinars. So tonight we have handpicked pediatric endocrinologists with high expertise in pediatric thyroidology, and we've done that nationally, regionally, and internationally for you, ladies and gentlemen. We have a distinguished panel of speakers, and I encourage you strongly to be engaging with us, and please put as many questions as you want in the Q&A bar that will appear. Now, if you can look at the agenda as it is flagged up by our organizers, you notice that the whole webinar will run for 2 hours, but I'd like to say or to point your attention that unfortunately we had to cancel the industrial webinar. We would like to utilize that time for further questions and discussion. So do please engage with us and utilize that time for more education and knowledge sharing. Thank you very much. At the beginning, ladies and gentlemen, it gives me a great pleasure to introduce an international speaker, our guest speaker today, Dr. Siobhan Pittock. Dr. Siobhan Pittock is a well-known pediatric endocrinologist who is joining us from a renowned international clinic, which I'm sure you all know, Mayo Clinic Rochester. Siobhan has special interest in pediatric thyroidology, particularly thyroid cancer, quite a hot topic that many of us, myself included, not very well trained on. So I'm gonna give the floor to you, Siobhan. Please utilize your 25 minutes. We look very much forward to hearing you and sharing your wisdom and knowledge in thyroid disease in pediatrics. Thank you very much.
Great. Well, thank you so much for the kind invitation. I'm sure it is a lot warmer where you all are than it is right now in Rochester, Minnesota. So today, obviously, thyroid cancer is a huge topic. I would really like to focus the talk today on a narrow area, and that is the approach to indeterminate thyroid nodules. This is an area of great interest, mainly because of newer tools that are available. I want to talk about some of those newer tools, but I want to ensure that we all understand the limitations of those tools also. So today we will review the American Thyroid Association guidelines for management of indeterminate thyroid nodules, share some literature on indeterminate nodules in children and their outcome, look at the updates and limitations of molecular diagnostic tools which are available, and I'm going to share our approach that we use at Mayo Clinic, but also an alternative approach that is being touted by many. So how do we get to an indeterminate thyroid nodule? A child doesn't walk in and say, I have an indeterminate thyroid nodule. Obviously, they present, there's a history, there's a physical exam, somehow a nodule is picked up. Sometimes that's a high-risk group, sometimes it's an incidental finding. There's an ultrasound happens based on the ultrasound and whatever scoring system you're using, it's stratified and a decision is made whether or not to proceed with a biopsy, an FNA. And then it's really, we'll focus on indeterminate cytology results being the focus of the talk today. Reminder, what are the indeterminate groups? And we all use the Bethesda system for reporting thyroid cytopathology. There are 6 classes. Remember, 1 is non-diagnostic, 2 is benign, 6 is malignant. So by definition, anything in between 3, 4, and 5 are all considered indeterminate cytology. So for the purposes of this talk, I'll talk about indeterminate cytology for of these groups 3, 4, and 5, and you'll see me throughout the talk just talking about Bethesda 3, 4, and 5. So a complicated slide, but one that we are all very familiar with. This is a really helpful diagram taken from the ATA guidelines released in 2015 for management of thyroid nodules and thyroid cancer in children. We are going to focus on this part of the algorithm. So if after an FNA, it is deemed that the nodule is indeterminate or suspicious, 3, 4, or 5, surgery right now is the recommendation. And so right now, the recommendation is simply to operate on all indeterminate thyroid nodules. Why is that? This is a very, very busy slide. I really don't want you to go through it in great detail, but these were all studies which preceded those guidelines, and they looked at the malignancy risk in nodules with various cytologic groups. You'll notice up here 3, 4, and 5 for some of the earlier studies. We weren't using Bethesda, so you'll see some of the boxes have those groups combined. But overall, looking at those pooled studies, the thought was indeterminate nodules have a 41% rate of malignancy. That's too high a rate of malignancy to ignore, and therefore all of these children need surgery. What type of surgery do they need for indeterminate cytology? The recommendation is to proceed with lobectomy and isthmusectomy. So take out the affected lobe, the isthmus, and then wait for pathology. And if obviously there is cancer, to proceed with completion thyroidectomy and a central lymph node dissection. So why is there a move to change? Well, several reasons. We want to get the right surgery the first time, if at all possible. Children having a lobectomy, waiting however long it takes in your center to get histology back, then having to go back into the operating room if they have a malignant lesion, that's dissatisfying, it's higher in cost, and increases the risk of complications. Also, if this really is benign, you don't want to shift and say, okay, if there's any suspicion, let's take out the whole thyroid. And if it's benign, you really want to just do the lobectomy the first time. You also want to avoid unnecessary surgeries. If we leaned on, I want to avoid resurgery, then you will do total thyroidectomy more commonly. And potentially, should we really be avoiding surgery altogether in some of these children? The question has also arisen, 41% malignancy rate in indeterminate nodules. Is that appropriate? Are we over-diagnosing malignancy or overestimating the rates of malignancy? And I would argue that we are, and I'll show you in a few slides why. The other issue to potentially change is that data was based on pre-2015. The guidelines came out in 2015. We now have many more tools in our toolbox. Can we do better? Can we do a better job at predicting malignancies so that we are appropriately treating children? The first thing to know is, what's the extent of this? What's the extent of this challenge? How often do we see indeterminate cytology? Don't worry about all of these specific slides. I pulled together lots and lots of studies looking at pathology, looking at cytology results where there was follow-up pathology available, just to show, much easier to look at it in this. When these studies are pooled, we have almost 2,500 thyroid nodules. We're all aware that thyroid nodules studies are smaller in children, but when we pool these studies, about 18% of all cytology results end up in that indeterminate 3, 4, or 5 group. So the majority are still benign, about 10% in this pooled group malignant, but almost 20% are in this indeterminate group. So it is not an insignificant group. There's also very significant variability center to center, with some groups having much more than 20% in that indeterminate group. So you may be in a center where up to 30 or 35 or even 40% of the biopsy results, of the FNA results that you're getting back, are indeterminate. But overall, not an insignificant group, close to 20%. So the first thing when I think of this is, are we following the guidelines? Were we following the guidelines? So for the purposes of this, I have the references here on the side. I looked at studies that were done before 2015, before the guidelines came out, and after 2015. Now remember, the guidelines say that if you have Bethesda 3, 4, or 5, indeterminate, you should operate. The studies suggest that we were not operating on all of these nodules. So looking at these studies, again on the right, there were almost 2,500 nodules with cytology. Those same groups reported histopathology outcomes. So those same group operated on a portion of their patients, and it was not the entire number of patients. So of these 2,500, there was surgical follow-up on only 39% of the patients. So clearly there's a very big mismatch. Arguably, before 2015, we knew no better. We weren't told to, it wasn't a recommendation, but post 2015 even, the recommendation was to have surgery on all of these, and yet that was not the case. Not surprisingly, a Bethesda grade 3, before the guidelines came out, these centers were operating on about half of the patients. Afterwards, a little more, 57%. Not surprisingly, as we go up in the scale, higher risk of malignancy, therefore more surgeries. So Bethesda 4, 65% were being operated on, Bethesda 5, 83%. If we were to follow the guidelines and truly follow that initial flow sheet, that initial algorithm, we would be doing 84% more surgeries for Bethesda 3 than historically done by this group, 50% more surgeries for Bethesda 4, and 22% more surgeries for Bethesda 5. So there's clearly a mismatch. I don't think we are missing 84% of malignancies in Bethesda 3, nor the big numbers in Bethesda 4 and 5. So where are the mismatch? Is it that we're overestimating the rate of malignancy? Remember, the pooled studies suggested a 41% risk of malignancy in these patients with indeterminate cytology. I would argue yes. It's all about the denominator. So when we're talking about malignancy risk, remember, if you have 100 patients, let's say with Bethesda 3 cytology results, Bethesda class 3, and you operate on all 100 and 50 of them have malignancy, then you can hand on heart say there's a 50% rate of malignancy. Okay. If you only operate, as we can see historically, on half of the patients, so you only operate on 50 of them because you decided those were higher risk, and 25 of them have malignancy, well, then you can absolutely say that there is 50%. The difficulty is people were operating on a small portion and using the full denominator, not using only the denominator for of the surgically treated patients. So I'm just going to show you this and ignore the piece on the right for right now. These were various studies. 63 of these 136 nodules, there were 136 nodules with this Bethesda, there were 136 nodules total. 63 of them had histology available. And of those group, Bethesda 3, 4 of them were malignant, only 9 of them had surgery. So you are suggesting a 44% malignancy rate. However, there were 10 in that category. So it's not so starkly obvious here, but you can see that the rate of malignancy drops if you include the full number who had Bethesda 3 pathology. So it can be as different as there were 2 malignancies in the Bethesda 3 group for this group. 6 of them actually had Bethesda 3, but only 4 were operated on. There's a big difference in saying there's a 50% malignancy risk and a 33% malignancy risk. What has been reported out in these studies as a malignancy risk is really a malignancy rate in those operated on. But clearly, not every child not operated on necessarily has that same malignancy risk. So it's a huge issue in looking back historically at all of these malignancy risks. So over on the right side, I want to point out 2 things. First of all, in blue are the higher reported malignancy risks when only those operated on are used in the denominator. So as high as 80% in the Bethesda 5, as high as 32% in the Bethesda 3. In the brown bars, you will see that if the entire denominator, the appropriate denominator is used, it's a lower rate of malignancy. What's much more stark, though, is that all indeterminate is not equal. Clearly, the rate of malignancy is much, much higher in the Bethesda 5 than in the Bethesda 3. So why should we be making the same recommendations for a Bethesda 3 as a Bethesda 5? So 2 big take-home points for this. Indeterminate is not indeterminate the same if it's Bethesda 5 versus Bethesda 3, and also always think of the denominator when you are reviewing these studies. And this denominator issue continues to be an issue even in later studies. So it's a big issue. So what else can we do? Well, some groups remember, we've only been operating on about half of the Bethesda 3. What are other groups doing? This is a nice paper from the Chirella group in 2019, who had 430 thyroid nodules, and they actually reported out what they did with some of these Bethesda 3 group. So they had 39 of the 430, and they just observed, and they repeated their biopsies. What happened? 8 of this 39 were actually on later biopsy deemed benign. 13 of them, 45%, stayed in that very gray zone. I would argue that Bethesda 3 is the most gray zone. And then 7 of the 39, or 28%, were up to 28% went up to either a 4, 5, or 6. So it is very reasonable to observe and repeat this. How about additional tools? This is the hot topic. This is what everybody's talking about. Don't forget the old-fashioned additional tools. We have our clinical history. We have our risk factors. We have the physical exam. We have the imaging studies. Let's not focus everything on this cytology. And people are using a variety of scoring tools, and I don't have time to go into those today. Remember, not all indeterminate nodules are very indeterminate. If you have something very concerning looking, if you have something that looks bilateral, that's going to look on ultrasound, that is going to be very different no matter the pathology results. And remember, not all benign is benign either, that up to 7% of Bethesda 2 nodules are actually malignant. So how about these molecular studies? Again, incredibly busy, not meant to go into enormous amount of detail with this, but back as far as the mid-1990s, people have started looking at molecular markers, so mutations in thyroid nodules in children. These were the vast majority done on pathology samples post-surgically, and some studies as low as 32%, some as high as 70%, but basically, bottom line, mutations are common in pediatric thyroid cancer. Those are the references used for that. There are clinical correlations with mutations. There are very clearly seen mutations that are higher risk and that are seen in malignancy. And there are also mutations, it doesn't have to be no mutation, but there are mutations that are seen commonly more commonly in low-risk lesions, but not necessarily absent in malignant lesions. So it is not a black and white, it's not a black and white. Certainly high-risk ones tend to be far more common in malignancy, but low-risk ones can be seen in malignancy also. How about this microRNA data that's being used very commonly on the adult side? This is a nice paper published in 2020 by the group in CHOP, just to share with you the pictogram, which I think they did a really nice job of. 66 of their 113, again, they were pathology samples post-op, 66 of them ended up being malignant. The ones in blue here were identified with microRNA abnormalities suggestive of malignancy, and the ones in brown here were the ones that showed mutations. So you can see in their hands, 53% of the malignancies were picked up by an abnormal high-risk mutation, 59% by these microRNAs. So they were highly specific. There were a couple of oncogenes present in benign lesions, but for the most part, if you have a mutation or if you have the abnormal microRNAs present, highly suggestive of malignancy. But if you haven't, there was still a almost 50% malignancy rate. So very, very, very important to realize what these molecular markers do. Very few studies done on FNA samples on these patients. The vast majority of studies are done on historical tumor blocks. This is a nice study that was done on FNAs. It was Monaco's group. There were 179 cases. Bottom line, of those who were mutation positive, and these were the mutations they found, they were all malignant. However, the mutation negative group, still almost a 50% malignancy rate. So remember, this is incredibly, incredibly important. Finding a mutation is a rule in, it is not a rule out. 50% mutation, a 50% malignancy rate is not good enough to say we're good, we're safe here. But if you have a mutation, absolutely, in their case, there was a 100% malignancy rate, and that can help with surgical planning. I do want to do a little bit of all right, let's step back from that for a second, and let's look at a numbers needed to treat analysis. If we assume that ballpark 50% of indeterminate nodules end up with malignancy, knowing that, you know, all of the caveats of the studies that I've shared before with malignancy rate versus malignancy risk. Let's just pick 50%. Let's just assume that mutations will be found as often on FNAs as they are on histopathology, which isn't a for sure thing, but let's assume that's the case. And let's assume that, as the limited studies have shown, about half of the tumors will have high-risk mutations. Let's walk through this. We have 100 patients with indeterminate nodules. Half will be malignant, half will be benign. Of the malignant, half of them will have a high-risk mutation. It's great. If you discover that, you're going to go straight to a total thyroidectomy. Half of them will have a no mutation or a low-risk mutation. You're going to go for a lobectomy, and you'll be wrong. You'll still have to do a completion thyroidectomy. I'm going to ignore the benign side right now because you're still going to do a lobectomy in those. So really, these are the patients that you're still going to get wrong. These are the 25 that you are going to, so of the 100, you're going to save repeat surgery for these 25. So just keep that in mind when you're determining kind of risk benefit, and you are still going to have a 25% reoperation rate. Okay. How about actual rates of malignancy? Because this varies. So if you assume a 50% rate of mutations, the actual malignancy rate in Bethesda 3 is much lower. So if you have a low malignancy rate, your reoperation rate will be even lower. So think about these Bethesda 5. If there's a very high malignancy rate and you are not going to jump to total thyroidectomy because you don't have a high risk mutation, you're going to have quite a high reoperation rate. This is assuming a 50% pickup. If you have lower pickup, the reoperation risk is going to be even higher. So always, always consider the pre-operative possibility. In our center, we use frozen section. We've been using it for over 100 years. And this was a study way back in 1997 to show that in the adult side, we were 78% accurate in at frozen section in determining the difference between malignant and benign. When I look back at our study, this was something we published in 2019. It was an imaging paper, but if we just use the outcomes data from our 3, 4, and 5, we had a 5% reoperation rate of all of our indeterminate nodules. We jumped to total thyroidectomy. We knew that straight away in the 5s. We deliberately did a lobectomy in one of our Bethesda 5s because it was a very small lesion. And only one of our Bethesda 4s did we need to do a repeat surgery because the frozen section was not consistent with the pathology. So here's our approach. So Bethesda 3, it's very reasonable to observe and repeat. If it is downgraded, you're just going to clinically follow up. If it is upgraded, we would argue for lobectomy and then frozen section. If you're nervous about doing that, if the family is very nervous, you could certainly jump straight to lobectomy and frozen section. And if malignant, completion total thyroidectomy and lymph node dissection. And we do that all in the one surgery because we have intraoperative frozen section. If you have Bethesda 4 and 5, our approach is to jump straight to lobectomy with frozen section, intraoperative completion total thyroidectomy and lymph node dissection. If you don't have frozen section, it's very reasonable again. Bethesda 3, you can observe and repeat the same thing again. Bethesda 2, you're going to clinically follow up. Bethesda 3 and 4 or 5, if you've done a repeat, you can consider an oncogene panel, certainly. And if you have high risk mutation present, go for total thyroidectomy. If it's absent, if you have no mutation or a low risk mutation, you're going to do a lobectomy, knowing that you may have to come back in a few days later to a completion. If you have Bethesda 4 and you have a low clinical suspicion, you could do an oncogene panel and follow the same. If you really have a high clinical suspicion, I would argue if you have a high clinical suspicion, because of the higher malignancy rates in Bethesda 4, that proceeding with a total thyroidectomy first operation is a better idea. And a Bethesda 5, again, if it's a Bethesda 5, but for other reasons, for imaging reasons, for clinical reasons, for family history reasons, you really have a low index of suspicion, then go right ahead and do the oncogene panel to try to help rule in the need for total thyroidectomy. But if you have a high clinical suspicion, I would argue that a total thyroidectomy and lymph node dissection is the way to go. So it's really important to know your team, know what the rates of malignancy are in your center for various Bethesda outcomes. Use all of the data to assess your risk, not just the Bethesda staging. And the preoperative risk should drive the decision whether to jump straight to total thyroidectomy or whether to use these oncogenes. High-risk mutations are rule in. The absence of a high-risk mutation should not necessarily be reassuring. And remember, if you find a low-risk mutation, it's the same as not having done the panel. You need to make a clinically based decision whether to go for a lobectomy or total thyroidectomy. And my fear with these panels is that they're very helpful in certain circumstances, but if they're used very, very broadly, we're going to actually increase our rates of need for reoperation because high risk that you know are high risk, if they don't end up having a mutation, you're going to do an inappropriate operation first time. And with that, I will stop. I think I went a little over time. My apologies.
Thank you very much, Dr. Petok. You didn't actually. You were spot on. You have 1 more minute. So thank you. So thank you very much indeed for sticking to time and updating us on this. Is a fascinating talk. I'm sure many questions will come up. And I would like now to introduce our second speaker, my friend and colleague, Professor Rasha Hamza from Cairo and Shams University. She's a very well-known pediatric endocrinologist in Cairo and in the region. Rasha is our Vice President of the Arab Society of Pediatric Endocrinology and Diabetes. And the floor is yours, Rasha, for another stimulating, entertaining 25 minutes. Over to you.
Okay. Good evening, everybody. Thank you very much, Asma, for the kind introduction and for the invitation by the Arab Thyroid Association. After listening to the fascinating talk on the indeterminate thyroid nodules, I'll take you to another gray zone in thyroid disease, and this is subclinical hypothyroidism. I'm trying to share my screen. Sorry. Can you see it, Asma?
Yes, Rasha. Yes,
Okay.
nice and clear. Go ahead, please.
Thank you. Okay. Simply, we all know that subclinical hypothyroidism by definition is elevated TSH with a normal T4. It's asymptomatic in most of the cases, and therefore it is a biochemical diagnosis, which makes things even more difficult. So when facing a child with subclinical hypothyroidism, these are the frequently asked questions by the parents and that even pop to our minds as doctors. Is it transient and will resolve? Could it progress to overt hypothyroidism? To treat or not to treat? A very difficult question, as I will show you. Is it a lifelong treatment or not? Now, looking closer to the clinical course of subclinical hypothyroidism in children, nearly half of the cases continue as subclinical hypothyroidism. 40% revert to euthyroidism, which is a quite good percentage, and only 10% develop overt hypothyroidism. This is to answer the question, is it transient or for life? And looking at the etiology, first, the classification of subclinical hypo in children, it's either mild when the TSH is less than 10 or severe if the TSH exceeds 10. On the right side box, in the blue box, you can see that Hashimoto thyroiditis is the most common, up to 80%, and some cases are idiopathic, and there's a long list lying in between. Remember that idiopathic subclinical hypothyroidism is self-limiting, and I will show you that you do not treat it except if the TSH exceeds 10. Subclinical hypothyroidism usually progresses to overt hypothyroidism if it's a part of Hashimoto thyroiditis or any associated autoimmune disease or chromosomal aberrations. And here you can see a very long list of drugs which interfere with thyroid function and could lead to subclinical hypothyroidism. On top of the list, anti-thyroid drug, and don't forget the anti-epileptics. So again, exclude drug intake in any child or adolescent with subclinical hypothyroidism. This could be the key to the diagnosis. Another important question, is there a long-term sequelae in children and adolescents with subclinical hypothyroidism? Does it affect growth, neurocognitive function, metabolic and cardiovascular complications, and is there an affection of the bone mineral density or not? This is an article published in the Journal of Clinical Research and Pediatric Endocrinology that assessed neurocognitive functions in children and adolescents with subclinical hypothyroidism, and they clearly concluded that patients with subclinical hypo have attention function, but the whole scale IQ was not affected in those children. Another study assessed the linear growth and intellectual outcome in children with long-term idiopathic subclinical hypothyroidism. And the conclusion here was that long-term pediatric idiopathic subclinical hypo did not affect growth and cognitive function. And this was published in European Journal of Endocrinology. And here you can see two tables. Here in the first table on the right side, you can see a non-significant difference in the height SDS, growth velocity SDS, and BMI SDS between children with subclinical hypothyroidism and controls. And in the other table, you can clearly see that there is a non-significant difference in the full scale IQ, verbal IQ, and performance IQ. Another study reported height improvement by L-thyroxine in treating subclinical hypothyroidism. And the growth velocity, SDS, assessed at 6 months, and at 1 year in the prepubertal group and pubertal group showed a significant difference after starting thyroxine. And they concluded that patients with short stature should be evaluated for subclinical hypothyroidism in addition to other potential causes. And L-thyroxine provides a significant improvement in height. But please don't take this broadly. We are speaking about those with short stature, in those who have height affection. But generally speaking, subclinical hypo does not affect the height. Thyroid dysfunction affects the bone mineral density. And by thyroid dysfunction, I mean hypo and hyperthyroidism, both by different mechanisms, could lead to demineralization of the bone and osteoporosis. An article published in Italian Journal of Pediatrics assessed the bone health in children with long-term idiopathic subclinical hypothyroidism. And you can see here that there was a non-significant difference between children with subclinical hypo and controls regarding the calcium, phosphorus, alkaline phosphatase, parathyroid hormone, and even the bone mineral density, Z-score, did not differ. And they concluded that bone health evaluated by lumbar spine DEXA was not impaired in children with idiopathic subclinical hypo. In spite of this, authors advised annual screening by DEXA scan being advisable in those children. What about the metabolic aspects of thyroid hormones in childhood? Indeed, thyroid dysfunction affects the metabolic status by acting on the liver, the muscle, the adipose tissue, the heart, and the blood vessel. And therefore, long-standing subclinical hypothyroidism could predispose to metabolic syndrome. And this is a long-term sequelae, especially in those with high TSH level exceeding 10. Now, looking into the mechanisms of cardiovascular effects of subclinical hypo, hypertension, inflammation, dyslipidemia, hypercoagulability, endothelial dysfunction, high homocysteine, and finally, high lipoprotein A. This is a quite recent article published 2019 that evaluated cardiovascular risk by growth differentiation factor and Doppler imaging in children with subclinical hypothyroidism. And the only abnormality found here was diastolic dysfunction of the left ventricle. And further studies are needed to explore the effect of thyroxine on such cardiac parameters. What about obesity? Obesity aggravates the situation even more. It predisposes to subclinical hypothyroidism, which leads to metabolic syndrome, and the vicious circle goes on. So how does obesity lead to subclinical hypothyroidism? It increases the fat mass, which increases the serum leptin, and this increases the TSH, leading to subclinical hypo. Also, obesity increases the fat-free mass, which increases the T4 disposal, and it gets lower. And this stimulates more and more rise in the TSH to increase the TF4 secretion. Even more increase in the free fatty acids, and the chronic inflammatory state which occurs in obese children leads to insulin resistance, metabolic syndrome, and this leads to more subclinical hypo, and again, the vicious circle goes on. This is an article published in 2017, Subclinical Hypothyroidism Compared in Danish Lean and Obese Children. And the authors here found a higher prevalence of subclinical hypo in obese than the lean, and central obesity by itself was an independent risk factor, whatever the BMI, predisposing to concurrent subclinical hypothyroidism. Another quite recent study published 2019 evaluated relationship of subclinical hypo with metabolic syndrome and its component. And they found that abdominal obesity and hypertension were associated with higher TSH levels and predisposition to subclinical hypo. Again, prevalence of subclinical hypothyroidism in obese is associated with other components of metabolic syndrome. And in this article, there was a correlation between TSH level, and LDL cholesterol, total cholesterol, and triglyceride. The higher the cholesterol, the higher the TSH level. What about NAFLD, or non-alcoholic fatty liver disease? This is an article that found higher TSH to be more associated with a higher left ventricular mass index and increase in the carotid intima media thickness. And here the conclusion was that obese adolescents with NAFLD and subclinical hypo have more adverse cardiovascular risk profile than those without subclinical hypo. And there was a question mark here that thyroid dysfunction might play a role in the pathogenesis of NAFLD, or non-alcoholic fatty liver disease. So how could subclinical hypo predispose to NAFLD? Hypothyroidism increases the NAFLD by increasing hepatic insulin resistance, increasing the leptin, fibroblastic growth factor 1, which causes more insulin resistance, and finally decrease in lipoprotein lipase activity increases the total cholesterol, leading to more NAFLD. Now, coming to the most difficult question that faces all of us, to treat or not to treat children with subclinical hypo. In other words, which way shall we go? To give treatment or to wait? A very difficult question. And the answer in most references is no clear consensus till now. Let me start by the story of this 8-year-old boy with accidentally discovered subclinical hypo. His BMI and height SDS are normal, negative family history, no symptoms at all, no goiter. The TSH is highish, and we always see this number, very common, 7.8. The free T4 is normal, antibodies are negative, and the ultrasound is normal. Would you like to treat or to wait? Can you help me with that? Okay, for the sake of the time, I'll answer. For me, I will not treat this child at this stage. No risk factors, because you can see in negative family history, antibodies and ultrasound are normal, the weight and height are normal, and no symptoms or goiter. So we'd rather wait. Now, 6 months later, the boy came back to me with the same parameters, but look at the TSH. It jumped to 12.2. Now, at this stage, would you like to treat or to wait? I'd rather treat at this stage in spite of not having any risk factors. But if the TSH exceeds 10, even in the absence of any risk factor, you must treat. So the TSH increased, we have to treat this boy because, as I told you, high TSH above 10 predisposes to metabolic complications. What about this 10-year-old boy? He came to me with a BMI SDS in the high normal, height SDS in the low normal. His maternal aunt has got Graves' disease. He's asymptomatic. He has goiter grade 2. His TSH is high, still less than 10, but it's a bit high, 8.9. His free T4 is normal. The antibodies are positive, and the ultrasound revealed goiter with heterogeneous echo texture. So there is a thyroid pathology by ultrasound. Who would like to treat this boy? To be honest, some pediatric endocrinologists would treat, others would not. For me, I would rather treat this boy because he has a lot of risk factors, even if the TSH is not above 10. His weight is in the high normal, his height is in the low normal. There is history of autoimmune disease in the family. There's goiter grade 2, antibodies positive, and there is a definite thyroid pathology by ultrasound. So we'd rather treat this boy. What about this cute 7-year-old obese girl? Look at the difference here. The girl is tall. Her height SDS is high. Her BMI SDS is very high. She's obese. She has simple obesity, negative family history, no goiter, free T4 is normal. Again, the crazy number, TSH 8.11, not so high, not normal. The antibody is negative, and thyroid ultrasound is normal. Again, what would you like to do for this girl? Who would treat this girl? Here, it's not advisable at all to treat this girl. Children with obesity are better put on a healthy lifestyle, and then you repeat the thyroid function and reassess. And this is what we did. The girl was put on a weight loss and healthy lifestyle, and 6 months later, she came with a TSH that went down from 8 point something to 4 point something without giving thyroxine. So please don't prescribe thyroxine for obese tall children. And this is a classical case, a 13-and-a-half-year-old girl with 45X Turner syndrome who came with the classical clinical picture of short stature at delayed puberty. At the beginning, thyroid function was okay. The T4 is normal, the TSH is in the high normal, antibodies are negative. The girl was diagnosed with celiac disease, and it's common to have antibodies with Turner. The bone age is delayed, 11 years, and the chronological age is 13-and-a-half. Of course, she has hypergonadotropic hypogonadism, and this is expected, partial horseshoe kidney, and she was started on sex steroid and growth hormone first. On regular follow-up, look at the thyroid function. She came with the T4 being normal, not perfect, but normal, and the TSH jumped from 4.5 to 8.5. So she developed subclinical hypothyroidism, and the antibodies are now positive. They were negative at the beginning, and the bone age is delayed 3 years more. What would you like to do for this girl? Would you like to start thyroxine or wait? It's better to start because Turner syndrome by itself, we said chromosomal aberrations by itself is a risk factor. In addition, she's deteriorating. Antibodies are positive, the bone age is more delayed, the TSH is rising, so it's better to start because in Turner, it will progress to overt hypothyroidism. And let me share with you this nice article published in Frontiers in Endocrinology entitled Subclinical Hypothyroidism in Children, when replacement hormonal treatment might be advisable. And here there was a very clear statement. The treatment of subclinical hypo is controversial in children. And the question was raised, when to treat a child with subclinical hypo? And the answer was, if there is a high risk of progression to overt hypothyroidism. And they listed two groups, the risk of progression to overt hypothyroidism. It's low if idiopathic, self-limiting, and that's why we do not treat idiopathic cases except if the TSH exceeds 10. If the baseline TSH is less than 10, the antibodies are negative, no goiter, no associated autoimmune disease, no chromosomal aberration, post-pubertal at diagnosis, and male sex. What about the high risk that we must treat? Hypothyroid-related subclinical hypo, when there is a definite thyroid pathology, if the baseline TSH is above 10, positive and rising antibodies, Turner, Down syndrome, other syndromes, celiac disease, prepubertal at diagnosis, and female sex. So these are the two boxes for the risk factor. What about the baseline TSH level? Please remember that TSH level at baseline is the most powerful predictor for progression of subclinical hypo to overt hypo. It's recommended by nearly all references to start thyroxine if the TSH is above 10, whatever the etiology, even if idiopathic. And there's increased risk of cardiovascular morbidity and mortality if the TSH is above 10, so we have to treat. And treatment remains a matter of debate for TSH ranging from 5 to 10. And this is the most difficult part, actually. This is the gray zone, TSH from 5 to 10. What about etiology as a predictor? As I mentioned previously, idiopathic subclinical hypo is usually self-limiting. And when there's a definite thyroid pathology, worsening of thyroid function is more frequent, especially if associated with autoimmune disease like celiac or other risk factors. So when you have autoimmune disease, you better treat. Treatment with thyroxine in children with hypothyroidism-related disease should not be under any debate, since the role of elevated TSH in coexisting cancer pathogenesis is possible. And what the authors mentioned in two references you can see below is that it is possible. It's not common, but having a TSH above 10 or a definite thyroid pathology necessitates treatment. What about the ATA recommendations for treatment of children and adolescents with subclinical hypo? Again, the very difficult question, to treat or not to treat a child with subclinical hypo, and the same answer, controversial in children. And here are the ATA recommendations on treating subclinical hypo in children. In the green box, better to treat if the TSH is above 10. Again, all references agreed. If symptomatic, if there's a high risk of progression to overt hypo, remember the 2 boxes that I showed you. Do not treat if the TSH ranges from 5 to 10 with negative antibodies, idiopathic subclinical hypo, no goiter, asymptomatic, no thyroid pathology by ultrasound. You just follow up the thyroid function every 3 to 6 months, and when stable, every year. And now here you can see the more difficult part, the gray zone. Consider treatment. This means that some pediatric endocrinologists could treat, others do not. If the TSH is more than 2 times the upper limit of the normal, and this is when it's above 8, progressive rise in the TSH, like the case I showed you, positive antibodies, goiter, child or adolescent with short stature, like the case I showed you, dyslipidemia or cardiovascular risk factor, and finally, when there is a thyroid pathology by ultrasound. And for the gray zone, it's very important to balance your decision. And here you must treat on individual basis. And this is the most difficult part of subclinical hypo. So there are pros and cons of treating subclinical hypo. Indeed, there are potential benefits. It improves the mild symptoms. It improves the lipid profile, but only if the TSH is above 10. Prevention of overt hypothyroidism, especially if the antibodies are positive. On the other hand, there are some drawbacks of treatment. Improved symptoms and lipids are unusual if the TSH is from 5 to 10. Potential for overtreatment. Remember, 40% revert to normal thyroid function without therapy, and this is a very good percent. And of course, the expense of the lifelong medication. So again, we have to balance the pros and the cons and take it case by case, especially in the gray zone from 5 to 10. And there are some tips to remember. Always start with a very small dose. The recommended dose is from 25 to 50 micrograms a day. And I personally like to start with 25 and monitor. Adjust the dose and play with 12.5 to 25 micrograms. And I'd like to play with 12.5 in subclinical hypo. Reassess the thyroid function, 3 to 4 TSH after 4 to 6 weeks. Follow up every 3 to 6 months and then annually if the antibodies are still positive, and every 3 years if negative. On the right side, you can see the very simple algorithm for managing a case of subclinical hypo in a child. And on the left side, you can see the pediatric workup for such cases. The free T4 and TSH, the antibodies, thyroid ultrasound, look for symptoms, goiter, and complications. Ask about the family history. Exclude medications, obesity, thyroid dysgenesis, adrenal insufficiency, syndromes, and renal failure. Now let me take you to this 10-year-old girl with midline neck swelling. The swelling was noted at the age of 2 years. It's soft, cystic, not tender. It moves with swallowing and protrusion of the tongue with no pain, discharge, or lymphadenopathy. And the girl is asymptomatic. Look at the thyroid profile here. The TSH is definitely high. The T4 is normal and the antibodies are negative. So this is a clear case of subclinical hypo. And when we did the neck ultrasound, we found a multi-septated anechoic cystic lesion, and thyroid gland was not seen in the thyroid fossa. So what is the next step? When we cannot see the thyroid gland by ultrasound, we must do thyroid scan. And look what we found. We found a thyroglossal cyst with ectopic thyroid gland inside the thyroglossal cyst, in addition to ectopic thyroid gland in the hyoid area. And again, thyroid gland was not seen in the normal position in the neck. CT scan was done to confirm the previous finding and to exclude malignancy. There is a risk of only 1% of malignancy if there is a thyroglossal cyst containing ectopic thyroid tissue. And to be honest, I did not ask for the CT scan because anyway, the cyst will be removed. But surgery did this, so the girl came with the report of the CT scan. So the diagnosis here is ectopic thyroid inside the thyroglossal cyst and infrahyoid ectopic thyroid. What is the suggested management in such a case? Again, removal of the thyroglossal cyst containing the ectopic thyroid because it could turn malignant. There could be superadded infection, and we will leave the infrahyoid and, of course, start thyroxine treatment because the girl has a TSH of 11 point something. In infants, the situation is even more critical. Take care not to slip. This is an 8-day-old neonate who had an uneventful birth history. The weight and length are normal. The baby is totally asymptomatic, but was found to have a high TSH on neonatal screening. The ultrasound is normal. Would you like to treat or wait? In such a case, we would wait. Now, let me share with you this nice article published in JCM on how to deal with infants with congenital hypothyroidism. If the TSH is above 40, you have to treat and do imaging. If the TSH is less than 40, take a venous thyroid function test. If the T4 is below the normal or TSH is above 20, you have to treat. And thyroid scan is mandatory if you cannot see the thyroid gland by ultrasound to exclude ectopia. What about the gray zone, TSH from 6 to 20? Retest after 2 weeks and do imaging. And again, do a thyroid ultrasound and or scan. So remember the neonate that I showed you, the TSH was 14. So he's lying in the gray zone. You just repeat after 2 weeks. And this is what we did. And look at the TSH when we repeated. The TSH profile, it jumped to 22. And as proposed by European Society for Pediatric Endocrine, you treat if the TSH exceeds 20. So the decision here is to start treatment for this baby. So this is the decision of treatment being so controversial regarding the gray zone when the TSH ranges from 6 to 20. In infants with mild subclinical hypo, this is from 6 to 10, 72% resolve spontaneously, which is a very good percent. So this is the list of indications of infants with subclinical hypo being treated. If the TSH is persistently above 10 for more than a month, if there are symptoms suggestive of hypothyroidism, or if there is a definite thyroid dysgenesis like ectopia. And here there are concerns about neurodevelopment and growth. And these are the doses that we give in thyroxine. And remember to keep the TSH in the age-specific normal range. And remember to keep the serum free T4 in the upper half of the age-specific normal range for the growth and mentality. My last case is this 14-year-old girl diagnosed with chronic kidney disease since 4 years. She's on regular hemodialysis, and she's totally asymptomatic regarding the thyroid. She came with goiter grade 2, and again, this number, a TSH of 8.2 with a normal free T3 and T4, negative antibodies, and the ultrasound revealed homogeneous enlarged thyroid gland. So this is a case of subclinical hypothyroidism associating chronic kidney disease. Now, let me ask you here, would you like to treat this girl or would you like to wait? We have a highish TSH, no symptoms, goiter, and there is negative antibodies. To treat or not to treat subclinical hypothyroidism in chronic kidney disease. Again, it's very controversial, but let me tell you that most references agreed that the state of subclinical hypo occurring with children with chronic kidney disease is a compensatory mechanism. So it is accepted until TSH reaches 10. So attempts of unnecessary thyroid hormone replacement in asymptomatic cases increases the muscle catabolism and could lead to negative nitrogen balance. But again, there is lack of consensus to treat or not. But most of the references agreed that there is no need to treat subclinical hypo in patients with chronic kidney disease if the TSH is less than 10, except if symptomatic. And if you decide to treat, start with very low doses, not more than 25 micrograms a day, and do careful monitoring for angina and cardiac arrhythmia. Again, an article published in JCM did the same, and they put a cutoff of 10 for TSH being proposed for treating subclinical hypo in children with chronic kidney disease. So please don't treat it except if TSH exceeds 10. So my final conclusions are subclinical hypothyroidism is less common in children than adults. Generally speaking, most of pediatric subclinical hypo cases resolve spontaneously, nearly 40%, which is very good percent. Decision of treatment of subclinical hypo in children is highly controversial. I've showed you most of the references. No one gave a clear statement except regarding a TSH above 10. Children with TSH above 10 must be treated, whatever the cause, even if idiopathic. Children with TSH from 5 to 10 are treated on individual basis based on the risk factors that we have mentioned. Children with idiopathic subclinical hypo are usually self-limiting. So if it's idiopathic, no risk factor, do not treat, except if the TSH is above 10. Children with hypothyroidism related subclinical hypo, when there is a thyroid pathology, usually require treatment and follow-up. Usually those with Hashimoto thyroiditis or thyroid pathology will need treatment. Obesity related subclinical hypo needs follow-up and weight loss is recommended. Please don't treat subclinical hypo associating obesity, except if the TSH is above 10. Again, you just advise weight loss and healthy lifestyle. And infants with a borderline TSH level, gray zone from 6 to 20 for infants, need close follow-up, and based on follow-up of the TSH, you can decide on the treatment. Thank you very much for your attention.
Brilliant. Thank you very much indeed, Rasha. I must convey the message that we have a lot of greetings, compliments, thanking messages from audience to you and to Dr. Petuk for these fascinating talks. Thank you very much. In the agenda, we were supposed to move to the cases, but I think it might be an idea just to spend a few minutes on some of the questions, because I think we might get overloaded at the end. And if I could start with a couple of questions, short ones with short answers, please. Let's start with you, Siobhan, if you don't mind. One question says, does radiation to head and neck increase the risk of thyroid cancer?
So I would say the important thing there is the neck. Yes, if it includes radiation to the neck. If it is just radiation to the head, no. So when we typically see it is much more commonly the children who get radiation to the chest and neck, let's say for lymphoma, would be much more common than, let's say, the brain tumor population. But certainly if radiation is, if the thyroid is in the radiation field, like the craniospinal irradiation for ALL, then we need to monitor not only for development of primary hypothyroidism, which we know happens not uncommonly, but also risk of thyroid cancer.
That's brilliant. Thank you very much. And if you don't mind, I have a question from my side. I'm really relieved that we will know more about other parameters that guides us to malignancy in these indeterminate nodules like mutations, microRNA, this and that. But I just have one query in my head. Our colleague Ali Zahrani is a very prominent researcher in the area, and he has special interest in thyroid cancer in children. And one of his publications say that the incidence of genetic mutation in some well-known genes like BRAF, for example, in children is far less common compared to adults. And as you said that studies in children are limited, I feel a bit anxious that if we are extrapolating data from adults, we might not have accurate guidance.
Yeah.
How would you
No,
answer?
you're exactly right. And in fact, until about 5 years ago, so BRAF mutations are incredibly common in adult papillary thyroid cancer. And until about 5-6 years ago, the thought was these do not occur in children at all. More recent studies suggest that BRAF mutations occur more commonly, but that they do occur. There is a very significant difference in the mutations that we see in pediatric thyroid cancer compared to adult thyroid cancer. We see far more fusion oncogenes, so far more fusions rather than mutations in pediatric cancers. What's interesting and where the jury is out a little bit is the genotype-phenotype correlation. There are some mixed studies. Some mutations tend to be seen more commonly in more aggressive cancers, and some with, I won't say indolent, that sounds benign, but less aggressive in terms of more simple, lower risk cancers. And so the idea is, to me, I think these mutations, and like I said, because I have frozen section, I don't use them preoperatively at all, but I realize not everybody has frozen section. To me, they're not useful enough as a preoperative mechanism for determining next steps in thyroid cancer, but I do use mutations in children who have recurrent or residual disease, because as we're thinking more about molecular treatments for the aggressive recurrent cancers, that's where I think the molecular markers are very helpful, because we are seeing more and more targeted molecular treatments for these cancers. There's a paper as recently as late 2020, which had, I think, 50 thyroid cancers, and they showed no genotype, phenotype, no difference in the mutation negative versus the mutation positive in terms of aggressive behaviors, size of tumor, multifocality, extrathyroidal extension, whereas that CHOP paper that I showed you with microRNAs, that one suggested that the ones with mutations behaved differently and that they were more aggressive than some of the others. So I think it's a little early to determine if having a mutation, I think there's good data that having a mutation is associated with malignancy. To me, there's not enough data to suggest that that tells us a lot more about the prognosis, but I think there'll be more to come.
Okay, great. 2 more minutes so we can have a short and precise answer, please. The second question can be answered by either of you before I move to Russia. So a person from the audience says, does subclinical hypothyroidism increase the risk of malignancy? So a question linking both talks. Can I have a short answer, please, from both speakers?
I'm going to say maybe, and then I'll put it over to Rasha, because to me, it depends on the etiology of the subclinical hypothyroidism. So over to Rasha.
Under certain situations, it's not in every case, according to the etiology. For example, the case that I showed, ectopic thyroid inside a thyroblastal cyst, yes, it could turn malignant. In others, no. I couldn't say yes, a broad yes or no.
Well, thank you, Rasha. That takes me to the second question to you, because from the audience also, one of the physicians says, I also have a child with subclinical thyroid and subclinical hypothyroidism in an ectopic thyroid, and this physician is asking, does it really increase the risk of malignancy? Do I need to take that thyroid surgically?
Okay, thank you for the question. Very challenging. The only thing clearly written in literature, if it is inside a thyroblastal cyst, where the ectopic thyroid by itself is not pre-malignant, and I think it's a good idea to do an ultrasound every year. Could be a good screening tool, but no, it will not by itself be a pre-malignant condition.
Okay, so it's the cyst that matters. Final question, Rasha, because you mentioned the ultrasound. The audience noticed, and myself noticed as well, that in every case you presented, you showed us features in ultrasound scan. So the question is it mandatory to do an ultrasound scan for children presenting with subclinical hypothyroidism?
Yes, a very big yes, Asma. I think this is an important home message, because sometimes the ultrasound is a good guiding tool. Because if you find a thyroid pathology, this is a risk factor, so you will start. For example, if the TSH is 8, it's not above 10, and I have a heterogeneous echo texture in the thyroid, it's advisable to start. So it's important, it's easy and cheap, so why not?
Okay, that's fantastic. Do please stay with us, Siobhan and Rasha, because we will need your expertise in answering more questions after going through some interesting cases. And now it's my pleasure to introduce my colleague, Dr. Mohammed Dbei, who's a pediatric endocrinologist from Riyadh and also our chair of education at the Arab Society of Pediatric Endocrinology. Mohammed has a very fascinating pool of pediatric thyroidology cases, and he's going to show us or talk to us about this unfortunate child who is 3 years of age. Mohammed, please, the floor is yours. Thank you very much indeed.
Thank you very much. It's a great pleasure for me to be with you, and thank you all for giving me this opportunity to listen to and discuss this interesting case. I will take you through the case.
Mohammed, do you mind changing it into slide view, please?
Okay.
Thank you.
It's okay now?
Yes, thank you very much.
Sure. So this 6-year-old child just recently seen in the clinic, he presented to the emergency room with noticeable neck swelling for the last 1 week, just prior to his presentation. Otherwise, he was doing well in his usual state of health. He had no respiratory or GI symptoms, and systemic review was unremarkable. As I mentioned before, the swelling was noticed 1 week ago by the family. He is breathing normally, doesn't cause any pain or discomfort. He eats and drinks well with no redness, no discharge or signs of inflammation. And it has not changed since they noticed in the first time. And also there was no family history suggestive of thyroid disease, cancer, parathyroid disease, or other endocrine tumor. But the past medical history was significant for this child. He had a refractory ALL. He's in remission. He underwent allogenic stem cell transplant 2 years ago, 15 months before his presentation. And he was conditioned with radiotherapy 2 years ago with almost 12 gray. He had a graft versus host. And however, this was well controlled for more than 1 year prior to his presentation. On examination, he looks well, playful child. His vital signs were stable. He's growing just in the 50th centile for height and weight. He has normal cardiovascular, neurological, abdominal, and respiratory examination. However, local examination of the thyroid gland showed generalized swelling in the thyroid area, more on the right side of the neck, with identified well-defined firm nodule, non-tender, roughly 1 by 1 centimeter. There was no increase in the size of local lymph node. So his basic workup for the thyroid function test was normal. His thyroglobulin antibody was negative. He had quite high thyroglobulin at 381. Other workup was also unremarkable. So is the child at risk for thyroid cancer? This was the concern. We know thyroid cancer is the most common secondary malignancy seen in childhood cancer survival. Prior history of radiotherapy typically seen in treatment regimen for Hodgkin lymphoma, CNS, and leukemia. So this patient was a cancer survival child, and he received radiotherapy. So he is at risk for thyroid cancer. So having this in mind, we proceeded with neck ultrasound, which showed both thyroid lobes are enlarged and heterogeneous. The right side with rounded hypoechoic nodule with central non-shadowing echogenic foci, area of calcification as shown in this scan, measuring 1 by 0.8 centimeter. And there is some lymphadenopathy, largest is 0.6 centimeter. So we proceeded after this immediately with the thyroid uptake scan, which showed localized cold nodule with 1.55% uptake, which normally from 1 to 4%, in the right lower thyroid lobes, which is suspicious for malignancy. So, so we have this child now. The case is building up. He is having ultrasound findings suggestive of malignancy, really concerning. So proceeded with FNA and findings suggestive of papillary thyroid carcinoma. And Bethesda system was category 5, and we know the risk of malignancy in this category is up to 75%. And already this Bethesda system reporting for thyroid cytoplasm was clearly explained by the first speaker, so I don't really have to go again. Just to remind you that there are 6 different diagnostic category, and our patient was in the category 5, which is suspicious for malignancy. So what is the next step? Okay, according to the management guidelines for children with thyroid nodule and differentiated thyroid cancer, ATA, which was published some time ago, and again showed if there is FNA suspicious for malignancy, then the patient should go for surgery. So immediately the patient was planned to do for surgery. The case was discussed in the tumor board, and the plan was for total thyroidectomy and review after surgery for possible radioactive iodine therapy. So total thyroidectomy was carried out and sampling of right and left cervical lymph node for histopathology. And the pathology came as papillary thyroid cancer, and margin of the gland were involved by the carcinoma with lymphatic invasion, no vascular invasion, nor extrathyroidal extension. And lymph node were positive for metastatic carcinoma. And his staging was P2, N1B, and MX. So just to explain this, P2 means that papillary thyroid cancer, T2 means that the tumor is more than 2 centimeters, but less than 4, limited to thyroid. N1B, lymph node, which is metastasis to unilateral, bilateral, or contralateral cervical level, or retropharyngeal or superior mediastinal lymph node. And MX, which is distant metastasis not assessed. So his classification was B2, T2, N1P, and MX. So again, another classification, whether to classify this patient at high risk, low risk, or intermediate risk. The American Thyroid Association risk stratification introduced and classify patient into 3 risk groups based on the risk of persistent or metastasis as low risk, intermediate, and high risk. The patient with disease limited to thyroid or without microscopic metastasis to a small number of lymph node considered as low risk. Patient with extensive central neck lymph node involvement or minimal lateral neck lymph node involvement are considered as intermediate risk. Patient with locally invasive with extensive lateral neck cervical lymph node involvement and or distant metastasis are classified as high risk. So based on his classification, he was put as high risk. So post-op workup identified really quite high thyroglobulin level, although there was some reduction, and with low 3T4. So we discussed him again and the second tumor board, and we did for him complete workup.
Mohammed, we can't hear you.
Okay.
Mohammed?
Yes.
Can you speak, please?
Yes, can you hear me now?
Yes, yes, great, thank you.
Okay. So the second tumor board meeting workup was done to complete workup for metastatic tumor and for radioactive iodine evaluation by radiation oncology. So post-op surgical thyroglobulin was quite high at 251 with high TSH. So we proceeded with neck CT, which showed area of enhancing soft tissue anterior and to the left of the trachea, likely residual thyroid tissue, with bilateral necrotic enhanced lymph node concentration concerning for metastasis. So likely this patient, based on the guidelines, he will need radioactive iodine, but first for surgical intervention for removal of the large residual tissue and for evaluation for the need of radioactive iodine after surgery. So the second surgical resection for this residual tumor was done, and removal of this tissue with the frozen section evaluation for margin showed clear margin without tumor residual. After second intervention, patients start to have hoarseness of voice, which improved with time. We discussed him again in the tumor board, and we decided for him to go for genetic panel for evaluation of predisposition to cancer and re-evaluation by radioactive iodine by radiation oncology, and for I-123 whole body scan. The pathology report of the second surgical intervention showed all tissue margin were negative for tumor. However, 2 out of 2 lymph nodes were positive for metastatic PTC. Post-op I-123 whole body scan showed residual functioning thyroid tissue in the left thyroid surgical bed with small focal activity in the right thyroid surgical bed. There was no iodine, avid local, regional, or distant metastasis, and a 24-hour iodine calculation of uptake was 4.74. So the patient was decided to receive radioactive ablation therapy, and patient was admitted to the hospital because of the age and difficult to isolate at home. So his father, we decided this was another challenge, how to give him a safe environment and given his age. So his father will be a sitter in the next room with a bed in the same room with shielding between the 2 beds. So the patient received radioactive iodine ablation therapy as per protocol. MBO for 2 hours, then he should receive good hydration, encourage frequent urination, gum chewing, and concentrated lemon juice, radiation safety instruction, and start thyroxine after 2 days. So I-131 whole body scan post ablation therapy, 7 days delayed whole body image were acquired. The patient was prepared with hypothyroid protocol. There was successful localization of the radio tracer in the thyroid surgical bed with no evidence of nodal or distant iodine avid disease. We know this patient to start with, he is at high risk for thyroid cancer, given his cancer survival, receiving of total body and nickel radiation. Okay, but we know that there are certain syndrome can also associate or increase the risk of thyroid cancer. We did for him extensive genetic panel looking for oncogenes. However, the workup was negative, and these genes include RAF, RET, RAS mutation, and all the genetic workup was negative. Now we are in the survival state. Now he is 2 months after the surgery, 1 month actually after the surgery, and according to the survival, according to the guidelines, he is considered as high risk, and we are aiming for suppressed TSH with a frequent follow-up. Also, we are aiming for to have low thyroglobulin according to a protocol. And I find this really quite challenging. How can I maintain suppress TSH level and at the same time ensure adequate growth and take care of bone? Since he's only 6 years and he's growing. So in conclusion, multidisciplinary team of pediatric oncologists, endocrinologists, surgeon, pathologists, and radiologists are really needed in to care of such a complex case. And the American Thyroid Guidelines provide a framework for management of pediatric thyroid cancer, although there are really evolving tools that help us in terms of decision making, like frozen section, and as mentioned by first speaker, genetic panel and micro RNA. With this, I would like to conclude, and thank you very much.
Thank you very much, Mohammed. That's very interesting. Let me take a couple of questions before we move. So Mohammed, just quickly, in the audience, they are asking you, how long was it between the 2 surgeries?
Almost 1 month.
1 month. Okay.
Or less than 1 month.
Now, my question to you, Mohammed, let's say retrospectively, would you have treated the patient any differently?
Probably will. The answer is giving, knowing his baseline risk, number one, as risk stratification. Probably he will go immediately for total thyroidectomy with lateral neck dissection in the same time, the same setting, to avoid the redo, because the redo creates some stress to the parent.
Okay, that's a very. May I move to Dr. Petuk? Siobhan, do you mind commenting on Dr. Mohammed's case? If this patient presented to you and not knowing what Mohammed told us, how would you have done anything different from what Mohammed did? Mohammed is not going to be offended, okay?
We're learning. This is learning experience.
No, I think, you know, afterwards there was clearly residual disease in the neck after the first surgery. And so we really try our very best to make sure that we, just like you said, you're retrospective, look. So we do pretty extensive lateral neck ultrasounds along with the thyroid ultrasound to begin with. Now, do we ever miss some residual? We all do, but our surgeons really do their very best to do. They use intraoperative ultrasound at times. They extensively investigate the opposite side if they're planning on doing a lobectomy. They interrogate, even just manually, the cervical lymph node chains during the surgery. And if frozen section was available first time round and frozen section revealed, my understanding as it was, revealed lymph nodes that were positive at the first surgery, then they would have extended the surgery at that time. So it's really about imaging and you know, acting on frozen section.
So just one final question before we move to the second case for both of you, Mohammed and Siobhan. You've used a genetic panel and it came back negative. My question is, do you think children panel should be different from adult panel, or do you think even our region might have different genetic abnormalities? Both speakers, please. Mohammed?
Okay. So I think I will love to do microRNA as a new tool for further workup. And this option is really, I would love to do it.
Yeah, okay. From my standpoint, I use, like I said, the genetic panel on the tissue. I'm assuming it was looking for somatic mutations rather than germline mutations, Dr. Ali Dabi. I assume that it was on the tumor itself. I think there are not, the mutations are different in children, but the panels that are used are very extensive. Certainly in the future, if people start narrowing down the panels, well, then for sure we would need to use a different panel than adults. But right now they're pretty extensive, at least the ones that I use. As for in your region, I don't know, because I don't know. Absolutely, there may well be differences. But I think right now you use the most extensive panel you have available, and then we continue to monitor. But for sure, the oncogene profile is different in pediatrics.
Somebody says, why bother about panels and extensive panels? Why don't you do whole exome sequencing?
So I can do that one. So these gene panels that we're talking about are gene panels on the tumor. So we're not talking about, you know, MEN, where a child has a germline RET mutation that predisposes them to tumor development. This is genetic alterations within the tumor itself. So it's not going to be picked up on whole exome sequencing. So it's somatic changes in the tumor tissue, not germline mutations that will be present all over their body. I would argue that after the fact, the gene panels aren't that helpful unless this child goes on to develop refractory disease. Hopefully, with what you've done, he's going to be tumor-free. He clearly needs ongoing follow-up. Now, whether he has a mutation or not right now, you're not going to treat differently because hopefully he had a good response to his treatment. But yes, it may be useful to know now for later if he becomes, but you can always go back to the tumor block and do the genetic testing also.
One last question, Mohammed, why did you make this child drink concentrated lemonade?
This will enhance as a protective for the teeth and enhance the salivation post-radioactive ablation therapy. It's very useful tool.
At least you can put lemon and mint, Mohammed. That will make it
okay. Thank you.
Thank you very much indeed. It's my pleasure now to introduce my friend, Dr. Abdelhadi Habib, who is our Secretary General of the Arab Society of Pediatric Endocrinology and Diabetes, Chairman of Pediatrics and Pediatric Endocrinologists in Al Medina, Kingdom of Saudi Arabia. He has a child with unusual thyroid function results that he's going to tell us about. Abdelhadi, the floor is yours. Thank you.
Yes, thank you very much, Asma, for the introduction, and thank you also for inviting me. So, as Asma said, I'm going to share with you the story of a young boy who was referred to us a long time ago with unusual thyroid function. And what I'm going to do is just to tell you the story, starting with the examination or clinical history examination and some laboratory and imaging, and then we will just try to share with you, or maybe just update you a little bit on the condition which turned to be the diagnosis of this child, and then I'll go back to the child to discuss the management. So this young man was referred to us at the age of 8 years from a local hospital because he was having pre-operative check for tonsillectomy, and the anesthetist noticed that he has some thyroid swelling here, very mild thyroid swelling. And he did a thyroid function test, which showed a high free T4 and T3, as well as raised thyroid function or thyroid stimulating hormone as well. So his TSH was 13, which according to Russia's talk merit further investigation or maybe treatment. In his local hospital, he was seen by adult endocrinologists who thought about pituitary adenoma secreting this TSH and leading to all this abnormality. And I think this is not a bad suggestion at all. And the child underwent pituitary MRI, which was turned to be normal. And this is his lateral view. And you can see he's, in addition to the thyroid swelling, he's got winging of the scapula. Now, this is a further look into his past medical history. He was described as failing to thrive until the age of 3 to 4 years of life. He's got also developmental milestones or delayed developmental milestones. And as I said, he tended to have recurrent tonsillitis, which justified his tonsillectomy. He was described by his parents as an hyperactive, having heat intolerance, and he's a poor sleeper, as well as performing badly in the school. And you can look at him, he's thin, and his height was on the 25th percentile, whereas his weight on between the 5th and 10th percentile. This is the family pedigree, and you can see here both parents and at least 3 of his siblings has got a similar pattern in that they have a high free T4, T3, as well as unresponding or unsuppressed thyroid function test. And you can see here the parents got, one of them has got relatively normal thyroid TSH, but I think this should be with the presence or with the high free T4 should be suppressed further, and the rest they got a high or maybe unsuppressed thyroid function test. This is the child as compared to the adult, and the family also got an elder boy who died at the age of 13, and I'll tell you about his story in a minute. So putting all these together, we thought about thyroid hormone resistance because the TSH or the free T4 and T3 were high and the TSH was not suppressed. And indeed, we sequenced the thyroid hormone resistance or the thyroid hormone receptor beta, which showed that our boy has a homozygous mutation in the thyroid hormone receptor beta, and the rest of the family with abnormal thyroid function test were heterozygous for the same mutation. Now, the most interesting thing, I think, in the story is this young man, his elder brother, he was also, who died early of heart failure. We managed to get his thyroid function test, and as you can see, he was following the same pattern, at least just before his death. And we think he's also got homozygous resistance to the thyroid hormone stimulation. Because of the story of his brother, we went through a detailed cardiac assessment, and as you can see, he's got this boy is good resting tachycardia, and reassuringly, his 24 hours cardiac monitoring did not really reveal any arrhythmia, but his both sleeping and resting heart rate were higher compared, not just for the control, but for patients with heterozygous resistance to thyroid hormone. We also had a baseline echo, which showed tricuspid regurgitation and mitral regurgitation, and he also has increased right ventricular systolic pressure. And in addition, his echo showed evidence, and MRI showed evidence of dilated cardiomyopathy. And you can see here, the left ventricle wall is relatively thin, and he's also got a patchy enhancement, post-contrast, and an increased area of interstitial space. And if you look at his numbers here, clearly he has a thin intraventricular septum posterior wall thickening, as well as relatively thin thickness. And this really indicate that, or confirm that the child has dilated cardiomyopathy. Now, before I get you into what happened next, I think just thought to update you a little bit about resistant to thyroid hormone, RTP or RTH beta, which is the diagnosis in this child. This is a very rare condition with just over 1,000 families reported over the last 55 years or so. And there isn't really a lot of data on the incidence, but I found 2 studies that were quoting different range or incidence between 1 in 20,000 and another 1 in 40,000. So it is very relatively or very rare condition. And as the name suggests, it's characterized by impaired tissue sensitivity to thyroid hormone action. It's caused by mutation in the thyroid hormone receptor beta gene. And so far, although it is rare, there were more than 150 mutations reported. The majority of these patients have heterozygous mutation like the siblings and the parents of this child. Only 6 reported patients so far in the literature with homozygous resistant to thyroid hormone beta, like the child I'm discussing with you tonight. Interestingly, although some patients will have the typical phenotype of the resistant thyroid hormone beta, approximately 10 to 15% of them has no identifiable genetic defect. The biochemical hallmark of the condition is high free T4 and T3 with unsuppressed TSH, which I already showed you in our patient and his family. It can be detected as diagnosed as or found as an incidental finding, could be presented with simple goiter or a picture of hyper or hypothyroid symptoms. And I think I have to say this can be easily missed, this condition. This is data from a very nice review looking at the percentage or the frequency of the clinical findings in a number of patients reported with thyroid hormone resistance. And you can see here goiter is the common or the most frequent presentation. And you can see most of these patients will have recurrent ear and throat infection and sensorineural deafness. And the rest is a combination of tachycardia, emotional disturbance, or a combination of thyroid hormone excess and deficiency, which can exist in the same patients. The management is variable, depends on the severity, but in general, most patients do not really need any treatment as they compensate for their receptor defect by secreting more thyroid hormone and remain asymptomatic. The symptoms usually improve with time. And so our aim is to relieve the symptoms, not to normalize the thyroid function test, because it is not an easy to do that. Now, for the mild form, sometimes they just have tachycardia, tremor, hyperactivity, which can be controlled by beta blockers alone. And I suggest, or the general feeling is, atenolol will be better than propranolol because it doesn't really interfere with the conversion of T4 to T3. Antithyroid medication can be used, but there are some reports in the literature showing that they raise the TSH and worsen the goiter, and happened with our patients, which I will tell you in a minute. And patients with this, with the hypothyroid spectrum, often need very high thyroid hormone replacement. Now, the treatment of the severe homozygous case like our patient is usually a challenge due to the risk of fatal cardiomyopathy. And we know this child's brother also died because of cardiomyopathy, and he has evidence of cardiomyopathy. And most of these patients will need agents to reduce the thyroid hormone TSH secretions. And the most famous one is the triiodothyroacetic acid, or TRIAC, which is very good agents to do that. There are other agents here. I wrote bromocriptine, L-DOPA, somatostatin analog, and also steroid, which they all can reduce the TSH secretion by acting centrally. Thyroid ablation using radioactive iodine or surgery can be tried, but usually risky in these patients, and I will explain in a little bit further. Now, these are the data showing the number of patients with homozygous thyroid hormone resistance beta, similar to our patient. And as you can see, they all have cardiac phenotype, and they were treated differently. So there is no consensus on what is the best treatment for this patient. So let us just go back to our patient. So it's got homozygous resistance to thyroid hormone beta. It's got thyrotoxic picture with cardiomyopathy. Parents and some siblings have asymptomatic heterozygous resistant to thyroid hormone. And most importantly, that his brother or his elder brother died of cardiac failure. So this child was initially tried on just beta blockers, and we started with propranolol and then atenolol, and it didn't really touch him at all. We add carbimazole for nearly 6 months, which was associated with rise in the TSH to more than 90 and massively increasing goiter. So we discussed the remaining options with the family and the experts, and the remaining option for this child are surgery, radioactive iodine, or maybe beta blocker plus TSH suppressor agents, TRIAC, plus minus carbimazole. But there are issues with the surgery and the radioactive iodine as well as the TRIAC. First, the surgery, it's very well known that these children with ongoing TSH stimulation, they tend to prompt or have regrowth of the remnant of the thyroid tissue. The radioactive iodine is also full of problems. First, the thyroid ablation in these patients has been associated with pituitary hyperplasia, which is very difficult to treat later on. And also the dose is not known, and it is expected that they will need a very high dose. And we know that the risk of high dose radiation causing thyroiditis, which leads to thyroid storm as well as cardiac decompensation. The beta blocker plus TRIAC plus minus carbimazole is an option. The TRIAC has been used in heterozygous thyroid hormone resistance beta, but may not really reduce the very high thyroid hormone or the FT3, FT4, and FT3 in our patients. So with this, just let me give you an idea about the TRIAC, because I'm going to talk about it a little bit in the management. This is a T3 analog with higher affinity for the mutant thyroid hormone receptor as compared to T3, i.e. it's really more liked by the mutant thyroid hormone than the T3, or the mutant thyroid hormone receptor than the T3. It suppresses the thyroid stimulating hormone secretion centrally without peripheral thyromimetic effect. It has a very short half-life, which is an advantage. But the disadvantage is that you have really to take more frequently, i.e. up to 8 hourly. It's very important to know that when you use this agent, you can't really rely on the assay of T3 because it will give you a falsely high free T4, but it's good for to know whether the child is taking the medication or not. And as I said, it has been used in 3 heterozygous RTH patients and 1 homozygous RTH beta patient. So with this in mind, we thought about the management plan, which we discussed with the family and Professor Chatterjee in Cambridge. And what we did is to continue on the beta blocker and then just try to add the triac, see if we can suppress the T4, T3. And if this is still high, then we can use carbamazole. And if both didn't work, we still have the option of using thyroidectomy. Now, this is just a summary of what we did over 50 months, which is just over 4 years. As you can see here, the atenolol 50 milligram continued all the way through, and then we started the triac a few months. And as you can see, the TSH or the free T4 was high. It went down nicely initially, but then it just stopped here. So we started the carbamazole, and we started going up with the carbamazole, trying to reduce the free T4, but this was accompanied by a rise in the TSH. With the help of titration of both the triiodoacetic acid as well as the carbamazole, we were able to get closer to normal free T4 and relatively lower TSH. This was associated with a reduction or improvement in the sleeping heart rate, and also a reduction in the brain nephrotic tide, which is an indication of the heart failure by the end of the treatment, or by the age of 4 years after treatment. The BMP were very nice. 6-hormone binding globulin, which indicate the thyroid hormone status, didn't really change, which is reassuring. What about the cardiac things? Because this is the main thing. You can see here, the cardiac index has improved, and also the ejection fraction remained within the normal range after 18 months and continued to be so. I mean, this is just the data after 18 months. And we didn't really find any significant change in the MRI, i.e. there was no deterioration. And we took this as a positive finding, and as well as at least we can say that the patient did not deteriorate further. What about the thyroid? This is the thyroid swelling. It was nice, but it was expected to get bigger, higher thyroid volume after 6 months of treatment. It didn't really lead to any pressure effect, and the same continued. And I think once we got the TSH down, the thyroid swelling improved a lot. What about the growth? Growth remained fine, height as well as the weight. He has better concentration and school performance as described by his parents. His heart rate, as I said, the resting heart rate improved, as well as the sleeping heart rate, and his energy expenditure has also went down. So it means that this medication is working, at least in the short term. So the message I would like you to take from this child and family is that individuals with heterozygous resistant to thyroid hormone beta can have normal life, and they can even parent children without any treatment. And we've seen both parents have the heterozygous RTB and have 5 or 6 children, and most of the child's siblings were the same, and none of them on treatment. However, the homozygous form of this condition is very serious and is associated with death and cardiac complication. And we've seen how the child struggled with the cardiac myopathy, and how his brother died at the age of 13. And we think that the combination of beta blockers, triac, plus minus, or maybe carbamazole, may be a useful alternative to thyroid ablation in these cases, particularly the ones with severe condition and potentially life-threatening hyperthyroid features predominance. Finally, I'd like to thank the child and his parents, and also my colleague Mohammed Mufid, who's pediatric cardiologist at Medina Cardiac Center, and both my colleagues Carla Moran and Professor Chris Chatterjee from Cambridge for helping us in the management of this patient and for conducting the genetic testing. Thank you very much.
Thank you very much, Abdelhadi. That's really fascinating. A couple of short questions so that we can finish on time. I find it really interesting what you are saying about the clinical pharmacology. I was impressed with how these pharmacodynamics and kinetics work. So you said TRIAC is a T4, T3 analog, yet it suppresses the TSH more than the original endogenous T3. That's interesting. The other interesting point, you said use atenolol instead of propranolol because you explained it has less effect or better effect on the conversion. So why don't we use atenolol rather than propranolol in our usual Graves' disease patients?
Well, I leave this for you to answer, Asma, because you're going to talk about Graves. But I think with these patients, it's in Graves' disease, you really want to reduce the thyroid hormone by any means. In this condition, you don't want to reduce the thyroid hormone a lot, because in some tissues, I didn't really talk a lot about the resistant to thyroid hormone, because some of them, they have mixed picture. They can have hypothyroid in some tissues and hyperthyroid in others. So you really want to be very, very careful not to overdo it. And it's better really to leave the free T4 on the 30s rather than below the normal range as we do in Graves. And I think that's the reason why we don't really propranolol. It might just suppress things further. I think you talked about, you asked me about TRIAC as well. I mean, this is the TRIAC, somehow the affinity of the mutant receptor to the TRIAC is more than the T3. And this is in these patients. I mean, otherwise you can say, well, why don't you use TRIAC for the management of other conditions with high TSH? But I think this is as far as I can explain it.
Great. Many messages, Abdelhadi, thanking you for your nice, clear presentations from different countries around us. So I thought it's my duty to convey these compliments. Thank you very much indeed. And I will shift to the final presentation by myself, and I'm gonna try and make it a quick one. I would like, ladies and gentlemen, to thank you for your patience, and if I may grab your attention for the final case that I would like to discuss with you. And I understand many of our audience are adults, so just this case highlights perhaps some differences between adults and pediatrics, even though the disease is the same. So this is, I'm not a thyroid expert. And I feel, I mean, a thyroid nodule gives me huge anxiety. I was very anxious throughout Siobhan and Mohammed's case, and I'm equally anxious about Graves' disease to a less extent. But let me just share with you this case, and you might find an excuse for me why to be anxious. So this is, I was told to see this 14-year-old girl. She presented to our emergency department with vomiting and dehydration, and I was called because at that time she had thyroid function test and was found to be abnormal. Prior to this acute history, she presented with 2 months history of abdominal pain and vomiting. It was quite dramatic as she has lost 10 kilograms within only 2 months. She was seen in multiple primary health care clinics, diagnosed with Helicobacter. She was also diagnosed with hyperthyroidism. But the problem with multiple diagnoses in children and this polypharmacy that some doctors prescribe, this girl ended up having bags of medication, so quadruple therapy for Helicobacter. And within that bag, a couple of boxes with carbimazole and propranolol. She was overwhelmed with this medication and she wasn't sure what to take and what not. And we were wondering which medication she took. Parents are relatively old and not highly educated. So there was a lot of misunderstanding of the diagnosis and the management. So she remained for 2 months, we think, hyperthyroid and perhaps taking some amoxicillin for Helicobacter rather than treating the hyperthyroidism. Her TSH was almost undetectable, quite suppressed, with a very high T4. And we were wondering how long did that continue, particularly that she has lost 10 kilograms within 2 months. So she was managed by adult internal medicine. There was this issue about pediatric age limit that we continue to fight about, but she was admitted to the ward and she was given anti-thyroid medication and she was started on intravenous fluid containing dextrose. So I'd like to highlight that, dextrose and saline. Until here, nothing exciting about the case, perhaps delayed treatment of hyperthyroidism. But the interesting part of the story is while she was admitted in the ward, she showed gradual weakness to the extent that she wasn't able to walk. And then she started losing consciousness and her sensorium started to alter and her Glasgow Coma Scale went down from 15 to 7 and required intensive care admission. Her admission in the intensive care showed features of hyperthyroidism. She was sweaty, tachycardia on and off, but she had this triad of neurological findings, including ophthalmoplegia, nystagmus, and ptosis. And she continued to have neurological deficits even when she started to recover. This is a picture of her showing the dramatic ptosis. She wasn't asleep in this picture, but she had this ptosis and she wasn't able to follow my fingers trying to examine her extraocular muscles, and she had rotatory nystagmus. So the easy part of the diagnosis is perhaps hyperthyroidism, thyrotoxicosis secondary to Graves', but we didn't know how to link the whole story within, namely the altered sensorium, the ptosis, ophthalmoplegia, nystagmus. And then when our neurologist colleagues examined her more thoroughly, they found that she is areflexic, hypotonic, and she had significantly reduced power, particularly in the lower limbs. And of course, she was encephalopathic. She was investigated extensively and thoroughly, endocrinology, immunology, neurology, you name it. From the endocrine point of view, she had normal ACTH, adrenal axis, normal prolactin. Her blood sugar remained normal with normal electrolytes and osmolality. Antibodies were positive for TPO as well as for thyrotropin receptor antibodies, indicating the possible etiology of Graves'. People thought she might have myasthenia gravis, but her acetylcholine receptor antibodies were negative. She had a thyroid ultrasound scan, nothing really exciting apart from increasing vascularities, but no nodules. And her thyroid uptake scan that I'm flagging up here, there was no thyrotoxic nodule detected in the thyroid scan. She had a lumbar puncture, which was completely normal in terms of culture, biochemistry, but there was some features of or suggestion of increased CSF lactate, which neurologists understand about it far more than me. She had a nerve conduction test, and that was significantly abnormal in the sense that she had major electrophysiological abnormalities and severe sensory and motor axonal neuropathy that was bilateral, but more significant in the lower limbs. The diagnosis was helped with the MRI, as the MRI apparently shows what it showed is very classical to the diagnosis offered by intensivists and radiologists. So there were areas of sharply symmetrical hyperintensity throughout the brain, thalami, midbrain, periaqueductal, gray matter, fornices, basal ganglia. It's like a mirror image of these abnormalities in both hemispheres of the brain, in the brain MRI. And then to my limited knowledge of this, I was thinking, what's this? Is this Hashimoto's encephalopathy? Is this Graves' encephalopathy? or is this a demyelination of some sort in autoimmunity combining Graves' disease? And it was the same person that I consulted, like Abdelhadi did. I consulted Prof. Chatterjee, Krish Chatterjee from Cambridge, who I must admit was really unable to give a precise diagnosis, but we were having very interesting exchange emails about the possibility of this. Now, neurologists, they have a more sort of posh behavior on this, taking the upper hand, talking about nerve conduction and other features than us endocrinologists, and they came up with all these interesting differential diagnoses, including Guillain-Barré syndrome, but none of us was really able to pinpoint what's the link between the neurology and the thyrotoxicosis in this child. And for some reasons, my slides, oh no, they're working now. The diagnosis, or what we think the diagnosis is, was pointed to by the radiologists, who said that this is an extremely symmetric lesions in the brain that we radiologists see in Wernicke encephalopathy. And they said one differential is multiple sclerosis, but the symmetry was too much, to the extent that it's not seen in MS. This is Wernicke encephalopathy unless proven otherwise. And for any of you who's like me, haven't got a clue what Wernicke encephalopathy is, it's a type of encephalopathy that's induced by thiamine deficiency. And it's seen in catabolic states, conditions like DKA, hyperemesis gravidarum, thyrotoxicosis as well. So what people were trying to put things together is this girl has been in a catabolic state for quite significant some time, losing a lot of weight, inducing thiamine deficiency. And when you have thiamine deficiency and then you have this catabolic state, then it induces the encephalopathy and you end up having Wernicke encephalopathy. Why am I convinced with that? I am convinced because I have witnessed by my own eyes how our intensivists treated this girl with intravenous thiamine, and how this girl, it was like a movie. She was sitting there with ptosis and ataxic and with her nystagmus, and after injection of thiamine, she started regaining her consciousness, and gradually even her motor and sensory activities improved. They also gave her methyl bread, so I had some difficulty persuading reviewers when I was trying to publish this case that this might be related to prednisolone and the steroids treating thyroid storm, rather than this story of thiamine and Wernicke that I was trying to sell it to the journal. I ended up publishing it though. So anyway, Wernicke encephalopathy is very well known. The mechanism I have already mentioned. I don't know whether it's convincing or not to you, but it's known to have a triad of oculomotor dysfunction, encephalopathy, and ataxic gait. And when we talk oculomotor dysfunction, it's ophthalmoplegia, nystagmus, and ptosis. So I thought that's a nice case to sell. What I also would like to tell you is how she nicely progressed. I mean, obviously she was treated for her assumed Graves with the traditional way of carbimazole and propranolol, not atenolol. And she regained her consciousness fully, she regained her ocular function, and gradually she was able to regain her motor function to the extent that she started coming for follow-up in clinic walking. She got rid of that wheelchair. And this is the growth chart that I'm showing you, and how she regained the weight she has lost in the last 2 months of her illness. Thyroid function test improved. And what's really interesting is after the treatment of the hyperthyroidism and the thiamine and the methyl pred, those hyperintensity areas in the MRI scan completely resolved. So this is how she looked when she had that disturbing neurological abnormalities. And this was 2 months afterwards when she was sitting in my office looking at me with this soft, sweet smile. So this is my last slide, and I just would like to put these things together. A 14-year-old child who had Graves' disease. We've seen the very high thyrotropin receptor antibodies. She went through the hypercatabolic state chronically for 2 months, and then she was rehydrated, given IV glucose, which at the background of thiamine deficiency, she went and had Wernicke encephalopathy, which resolved completely with thiamine replacement. And with that, I would like to stop, ladies and gentlemen, and thank you very much sincerely for listening to me. Okay, I'm just trying to look at some questions about this particular presentation. One colleague said, please share with me the case, the journal that you published. I published it in, oh, I can't remember now, but it was the official journal for one of these societies. Please email me. My email is adib@ssmc.ae, and I will send you a copy of the case report. Apologies, I cannot remember. And I think what we did tonight is, I didn't go through the agenda religiously, because I thought there were many questions coming up, and the speakers did a fascinating job replying to them. So I don't have any new questions in the box, but let me spend a minute or two asking the speakers, please, our great speakers, if any of the four of you, please, have any comment to make. We have like 2 or 3 minutes, which I'd like to open the floor to you with. Any tips to take home, any burning question, anything you would like. Let's start with you, Siobhan. Let's go by order.
No, this was a lovely 2 hours window in my Saturday morning. I think these were fascinating cases, all of them. So I'm just very grateful for the opportunity to participate. Thank you.
Thank you very much, Siobhan. Rasha, what have you got to say?
It's a really fantastic webinar. I've learned a lot. A very nice bunch of thyroid cases. It's really interesting. Thank you for the invitation. And I hope it was useful. I think everyone enjoyed it. I hope so. Thank you.
Thank you very much, Rasha. Mohammed, are you still with us?
Yes, he's here.
Yeah, I think it was very nice evening, scientific. Just would like to conclude with the thyroid cancer in pediatric is existing. Please look carefully for this condition. The good things is the survival is good, but we have to keep an eye on this condition. Thank you.
Thank you very much, Mohammed. Abdelhadi, what would you like to say?
Well, I'd like to ask you a question.
You're not allowed. We are past the time. Go ahead, Abdelhadi.
Yeah, I mean, just with the thiamine deficiency in your patient, any idea about her hemoglobin? Did she develop anemia as well?
Her hemoglobin.
Yeah.
Of course, I know you are a fan of megaloblastic anemia, and I know of your publications on the combination, but I cannot remember what had it. This is an old case, but it didn't strike me at that time that she had anemia. I don't know, Abdelhadi, okay, whether she had anemia, and particularly if her anemia was megaloblastic. But do give me 2 days and I'll come back to you with that. Thank you very much. But you cannot escape. You have to say something.
Well, I think thank you very much, Asma, and congratulations for forming this Arab Thyroid Association, which I think is confusing with the ATA, but I can see a small R after the first A. It's RTA or something like this. Yeah, I mean, I'm really pleased to have a dedicated session for pediatric thyroidology, because this is something we don't really have the opportunity for, even in a big endocrine meeting. But I think it was really nice, and I don't know, I mean, hopefully next time we can, I can get you a better case, or maybe something more interesting than the one I showed you.
Okay, well, that's fantastic. Let me take the opportunity to thank you very much indeed, the speakers. It was really fascinating what you have told us. And also, I'd like to thank you sincerely, ladies and gentlemen, for staying with us until the end. And last but not least, I would like to thank Dr. Tariq Al-Had. Dr. Tariq approached me to put together this symposium and pick the speakers. And I hope I have met your expectation with this strong panel of distinguished speakers, Dr. Tariq, Dr. Nasser Jahani as well. Thank you very much indeed for all the work and the support. And last but not least, also, like Abdul Hadi said, do please remember pediatrics. I might be biased, but pediatrics is interesting, and pediatric endocrinology is fascinating. Not everything you see our colleagues in adult endocrinology is the same. So if you invite us more, you're gonna hear different stuff that's really exciting and interesting. And before I close, I would like also to suggest that we work together. I did approach Dr. Abdul Hadi Habib and suggested, Abdul Hadi, shall we put our cases together of thyroid resistance? And he ignored me. So this is another request. Perhaps we can pull Siobhan as well with us with multiple case series. We can see the difference between the American population and our regional patients, and then get Mohammed involved and look at the genetics and the huge pool that Rasha Hamza also have. Okay, ladies and gentlemen, I think I need to close. We are 5 minutes past our allowed time, or 7 minutes actually, but I'm sure that's worth it. Thank you, everybody, and thank you, our organizer. Have a lovely rest of your day or evening or whatever. Thank you very much now. Thank you.